Hi, I'm Allison Betof Warner. I'm the director of the Melanoma program and the solid tumor cell therapy program at Stanford.
Hi, I'm Ben Creelan. I'm a thoracic medical oncologist at Moffitt Cancer Center with a specialty in cell therapy.
All right, so Ben, we just had a great session. Why don't you talk a little bit about what we learned about lung cancer and some of the targets, TILs, and other cell therapies?
Yeah, I think lung cancer is kind of emblematic of what's changing in solid tumors right now. We have tumor-infiltrating lymphocytes that we've stolen from you guys in melanoma and started to launch, registration trials for bulk TIL unselected tumor-infiltrating lymphocytes in lung cancer in the second-line setting. But at the same time, there's genetic edited TIL, which have the promise of avoiding IL-2, probably the one treatment that we have the most side effects for patients, right?
Yeah, I think especially in lung cancer. I mean, IL-2 is really challenging in melanoma, no question, and is still really limiting for our patients in melanoma. But, as we both know from treating lung cancer patients, really hugely limiting.
And we know that tumor-infiltrating lymphocytes spend the first 48 hours of their lives in the lung tissue from National Cancer Institute. And so I think the combination of IL-2 and TIL for people who already have a low lung reserve is more of a challenge, and so being careful with how you dose it and making sure those people are really, dry going into it, low amount of extra volume is important.
Yeah, so beyond bulk TIL, what do you see in lung cancer right now?
Yeah, so we've got, of course, the genetic edited TILs. The IL-15 membrane bound seems to be a promising approach. And of course, we've got CARs and TCRs that are applicable to a subset of lung cancers. Again, many of which we've stolen from melanoma, PRAME.
We lead the way. We lead the way.
PRAME seems like it's probably one of the most, that's got to get approved for melanoma before long, right?
Well, that's a registrational trial, just opened. But I think the PRAME TCR is really exciting. In the melanoma space, we're seeing 54% response rate. And if that holds anywhere near that, I think undoubtedly we'll see an approval there.
Yeah.
But a registrational trial that just opened, so we're a bit out from seeing an approved product. But I would love to see this come. As Dr. Luke showed in his talk, PRAME is a great target in melanoma because it's expressed in over 90% of all melanomas. But there are a lot of potential other solid tumors where this could be a really solid approach.
So if it was today, you had a patient and you could just infuse, let's say, off trial, a PRAME TCR or an IL-15 membrane-bound TIL, would you do it?
Off trial, no, because I think we're really obligated to learn.
Okay.
These are early days, right? We have small numbers of patients treated on phase 1 trials.
Okay.
But, that PRAME TCR trial is a perfect example. We are now seeing that trial and others starting to randomize against standard of care bulk TIL. Mm-hmm. So that PRAME TCR trial, the IMA 203 trial, is randomized against physician's choice. And one of the investigator choices is lifileucel. Wow. So, if we have a patient who walks into our clinic who's looking for a cell therapy approach for melanoma, right, we are putting them on that SIR-PRAME trial to answer this question.
Absolutely. And so I think from your standpoint, you're seeing the TCRs, you're seeing the TIL. As far as CARs go, this is a way to get around the HLA loss of heterozygosity, which was kind of a theme of the meeting so far, that it's a big problem. But do you see any CARs coming out in melanoma?
CARs I think are a little further in melanoma, though there are several CAR trials, in fact, one at our institution that's about to open. The cell surface proteins have been harder to target in melanoma, and the on-tumor, the on-target off-tumor toxicity can potentially be really challenging, and so. I think CARs in melanoma specifically are a little further behind because we've been blessed with the success of TILs and then potentially TCRs. You talked about some promising CARs in lung cancer.
Yeah, of course, these are more validated. GPC3, amazing responses in hepatocellular, and it's 60% of squamous lung cancer. DLL3, clearly a nice bite, but those bites weekly, every 2-week infusions. What if we just had a one-time infusion of DLL3, as we heard from Dr. Gormley from Lawrence Link Kettering earlier in the talk? What if we had a TCR, like you say, against P53? I think that's another theme that these MAGE or P53 new antigen targeting TCRs, right?
I think we can't overstate the value of a one-time treatment. Right? I get asked this a lot, but why do you need a cell therapy if you have a bite already? Well, a bite is weekly treatment, requires hospitalization for the first several doses. It still has CRS potential.
Still has neurotoxicity.
It still has neurotoxicity potential, right? These aren't non-toxic, and they're weekly. If we're going to take those risks, then why not explore these as a one-time treatment with potential durability, as opposed to something like a bite where you are, perpetually redosing the patient.
Yeah, and the patient's quality of life, when you see these people, you were talking about the patient who is a super responder, you saw, a year later, they're, it's pretty amazing.
Right. I think the data, certainly as we know it from melanoma, where there's more historical data, but if we can get patients to a complete response with melanoma TILs, they are functionally cured of their melanoma, right? We have, these data from the NCI that says if patients get to a complete response with TILs, 96% of them are melanoma free at 10 years. So, I think this is where we really need to be focused, is not just getting those responses, which we want, but how do we start driving this towards CR? Because we all know that cell persistence is also a problem. So we need to clear the tumor early, and we really need to get that tumor.
Yeah, and I think minimal residual disease is the perfect setting for cell therapy.
Couldn't agree more.
This is the time when we're able to actually eradicate drug-tolerant persister cells. It's not going to be with chemo. It's probably not going to be with TKIs. And you're probably not going to get very far with bites if you're going to have to give it every 2 weeks.
Right.
But if we can think of these as consolidation treatments after first line or during first line, that'd be a great.
Totally agree. I think, as we mentioned this morning, we're really reliant on having good, if not better than we currently have, MRD assays. Many solid tumors still don't have an approved MRD assay, and the sensitivity and specificity of them isn't great yet for many solid tumors. And so it's hard to think about designing a cell therapy trial based on a technology that's already not quite there.
Right.
But I think it's coming for sure.
Yeah. I think we have cell therapy envy, at least in lung cancer. We want to get it into our field, and we're slowly making some steps.
We led the way for you. You're coming. So.
Yeah.
All right. Great discussion. Thanks, Ben.
Thank you.